delivery in Nigeria, which is the Basic Healthcare Provision Fund, otherwise known as BHCPF. So this clearly represents Nigeria's promise to make basic healthcare accessible to every citizen. It is funded jointly by states, federal, and local governments to strengthen primary healthcare across the country. Now, the red letter recently was released in October or thereabouts. It says that 32.9 billion naira was announced under this fund, a major policy move. But what does it actually mean for journalists and the beneficiaries? So would Dr. Davidson would help us, from this session understand what this release means in practical terms for citizens and journalists tracking the story. She would also help us understand the role of journalists in bridging the gap and not asking how much was released. She would also help us determine which she would help us understand what determines which PHCs are onboarded and how journalists can help track equity in this process. And most importantly, should help us understand how journalists can help citizens understand these financial pathways and identify where the bottlenecks may occur. Of course, before we continue, I would now take a brief bio of Dr. Davison. Dr. Davison leads the Strengthening Healthcare Systems. She doubles as the administrative lead at Budget, a civic organization that applies technology to intersect citizens' engagement with institutional improvement to facilitate societal change. She is a medical doctor with over 10 years of progressive experience in clinical practice in INGO and the United Nations. Her background is in medicine, public health, and child and adolescent care, with an advanced degree program in program management and global mental health. Her experience cuts across strengthening healthcare systems and health promotion, human development, community engagement, and development, community engagement and development, and citizens' engagement in fostering accountability and transparency. She has led several development projects with international organizations. She's passionate about young people and is committed to contributing positively to their capacities. So at this point, I'd like to call on Dr. Davison to please take the floor.
Okay, so I'm on the call. Just give me a minute, please.
Okay, so we'll give her a few minutes to take the stage.
Okay, beautiful morning to everyone. Apologies, I had to get my headset, but well, it's a privilege and it's also an honor to be in the midst of journalists. I remember when I was growing up, I used to think like, these guys talk for a living. And unfortunately, we're in the same room now. We're all talking for a living, but we're actually thinking of how do we spread the right information? How do we engage the right citizens? My name is Biobele Davidson. Please kindly let me know if you can hear me, Ogie, or whoever the moderator is
Yes,
on the panel.
I can hear you. And this is Uge. Yeah.
Okay. Hi, Ogie. Nice to meet you.
Nice to meet you too.
Okay, so first of all, the work of a journalist is something that is underestimated and under-recognized because you are the truth bearers. You are the people who keep us informed. You are the voices of the people. And as we look at the healthcare system, we find out that there are a lot of gaps. And these gaps are not happening because you're not doing your job, but these gaps are happening because the citizens are not actively participating. Journalism is not just a profession itself, it's a call of service. You are actually viewed as essential staff because you keep the ball rolling, you keep the people informed, you tell us the stories, you tell us the truth. People can be able to tell you what the situation is and you convey it in the right information. So having to take this topic for me is a privilege, like I said earlier, but it's also a contribution to telling the story of shared responsibility. And in terms of health system strengthening itself, the media is one key component that cannot and should not and would not be overlooked because you are the voices of the community. You are the ones who engage with them. You are the ones who are the medium for for telling the stories, for transcribing, for translating, and for engaging the stories. So we're going to have a conversation. I'm going to share my notes. You would all have the floor to also engage. So please, if you have any concern, if you have any questions, we'll hold the thoughts down. You can pen it down in the chat box. And then if you also need to ask questions, Oge will help me in coordinating the room so that we can all maximize the time and ensure that we finish on time and also carry everyone along. So please, there are no right answers. That's my line. There are no right answers. There are no wrong answers. But there are only answers. There are only questions that are asked in a proper manner, in a respectful manner. And most of these engagements that we are having is not that we are trying to fight the government. No, we're trying to come in to say, how do we understand the situation itself? First of all, we have to identify the problems that we have in the health system. How do we now understand this? How do we now contextualize that understanding to our own local context itself? And then lastly, how do we engage? By engaging, you must go with the right information. Yes, we may be able to appeal people through emotional stories, through all of those things, but when we're not coming with facts, you can't hold the conversations any further. So I'll share my screen. Please just give me a few minutes and kindly let me know if you can see my screen. Can you see my screen, please?
Yes, I can see your screen. Please, can others
I'll put
confirm
it
that they can
in,
see it?
I'll put it in slideshow.
Yes, I'm still seeing it.
Okay, so storytelling. Previously, in terms of journalism, or in terms of engagement with communities, a lot of persons would just come in, and I remember when I used to watch the news as a child, my dad would just put on the news and he would just say, NTA is coming on. And then all of us would just go and sit down and we're listening, and we're listening to some of those great people that we know who have contributed to this engagement itself. But one thing about the information at that point is that if there's nothing striking, the information is lost. It's also like when you want to spread information sometimes, when you're spreading information, if there's that connection, people tend to remember the stories you told more than the fact itself. They begin to affiliate themselves to say, it happened to that person. Now wow, it can even happen to this in this our community. Now the information begins to travel. But sometimes along the way it's of it traveling, the information gets distorted. So I think a lot of persons, especially the brains behind, came together and said, no, how do we reshape our news engagement? Especially because when you tell stories, you capture different cadre of people. You capture people with a lot of experience. You cater for people without no experience. You also cater for people who have a vast knowledge base. You also get to people who do not have a vast knowledge base. So those disparities sometimes make it difficult for you to be able to get the right people who need the information. And that's where the media comes in. And sometimes if you look at children, when you're engaging children, and then you're singing songs of 1, 2, 3, and then they're dancing, they tend to remember those songs. Now, if you say count 1 to 20, the child is staring at you, but if you start singing 1, 2, buckle my shoe, they follow you through. And that's because you've been able to coin the information to their context. So basically, we're going to start with, first of all, before we go to the red letter and all of that, let's have some basic parameters that we can all align on, and then we'll take it from there. So what is the BHCPF? The BHCPF is an acronym for the Basic Healthcare Provision, and it's a program that was established under Nigeria in 2014. And sorry, please, just 1 minute, excuse me, just a minute. I think I moved my cursor. 1 minute, please. Okay. Please let me know if you can still see my screen. Just a minute.
Yes. Okay.
Okay. Thank you. So the Basic Healthcare Provision Fund was established in 2014, and it's part of the National Health Act, which was signed by, and then it was also pushed by the Nigerian Health Sector Reform Coalition, whereby a group of healthcare professionals came together and said, oh, we need to do something about being able to cater for everybody. Now, it is like a memorandum that was signed between the healthcare practitioners in Nigeria and then also the government itself, with the goal to enhance health infrastructure, to ensure that at least everybody who is able to visit a facility has basic minimum health package. And then also is also able to cater for the provision of financial resources for emergency medical care, to be able to cater for operational expenses, essential commodities, health worker support. And then also it also helps us in looking at ensuring that anybody who walks into a hospital has access to health coverage itself. So in ensuring that we are able to achieve universal health coverage. Now, this fund is sourced from a portion of the federal government consolidated revenue, which is 1%, as well as grants and contributions from international partners and other partners and private entities. So now I'm going to relate this back to some of my experiences that I've had in the previous years. I remember when I worked in a facility, a beautiful building, outside, manageable on the inside, and essential communities were a problem, especially in emergency. So imagine working in like a 30-bed facility of young children, and then there's an emergency and you say, go and buy this. And then the person has to run from one building to the other building. And then you're running towards the emergency tray to say, can I have this thing? And they say, we don't have. Why? The last person that used it has finished it and they did not replace it. So it was a bit draining for a lot of us, especially because we came in from systems where these things were available and they were handy and they were easily replaced. Now, in emergency situation, you would say, but it's one case. Why didn't you follow up with the refund? Imagine now there's like a mass casualty and then it's available, but it's only in limited amounts in the emergency tray, and everything gets exhausted at that time. What do you do? And then the relatives of the patients are shouting, doctor, do something. The nurse is there. You have limited human resource, but you're also struggling with commodities. So basically, that's what this money was meant for. So it's a pool of money that is set aside to make sure that health services reach everybody, especially those who cannot afford. Now, the key functions of the basic healthcare provision funds, there are a lot of them, but I'll just go through them one after the other. One is to strengthen the primary healthcare. So this money is used for critical purposes, especially when you have major repairs. For example, there's this hazardous wind that blew and took off the roof. Should we be waiting for the state government, local government, or the state government to come and fix that? This money was supposed to address that. There are reusable medications that are supposed to be in the emergency tray, and now they are out of stock, like the story I just told you. Should we be waiting until the next supply comes? Basic Healthcare Provision Fund is supposed to address that. Oh no, we have locum staffs among us that are supposed to receive some stipends. And do you know, it's quite amazing to find out that there are people who have been volunteering in hospitals for 15, 20 years, and they are still receiving 20,000, 30,000, 50,000 out of the graces of the in charge at that facility. Basic Healthcare Provision Fund is supposed to address some of these things. Then it's also supposed to fund minimum basic healthcare packages. So looking at some cost medications that can be easily provided for, like family planning medications, ANC, postnatal, this basic healthcare provision fund is supposed to ensure that people who are disadvantaged with a lot of insecurity ongoing. Sometimes one time when I walked in one of the hard to reach area, I saw something that I don't think anybody should have to experience. And it's a situation whereby you had a life, you had your family, you had your livestock, and one morning you wake up and everything is gone. Everything. There are people who have been forced to lose everything, except some of them even lost their lives because of what? Insurgency, because of displacement, because of, sorry, please. Yes, you can go. Next time. Because of occupation, because of hazards that they didn't plan for. So this basic healthcare provision fund is also supposed to ensure that when these people come to our hospitals, they have some form of dignity. They're treated as human beings. And they've come again. These people that will not come with money, or people want to address them and they say, those people that are coming from the camp, the IDP camp, or from the displacement camp, or from the, you understand? So basic healthcare provision fund is supposed to ensure that when these people come in, they have some form of cover for them. Now, secondly, it's also supposed to enhance public health security. In cases where we have disease outbreak, in cases where we have issues that require us to move people immediately, there's outbreak of measles, there's outbreak of this, there's outbreak of that. Before we begin to start doing our surveillance and all of that and trying to request funds and have those meetings and all of that, Basic Healthcare Provision Fund provides us that money to say, look, this money is in the storehouse, this is what we can purchase at this moment, this is what we can do. Lastly, it ensures access to quality healthcare. A lot of you, I'll ask a question, and pardon my way of talking, it's more of a discussion, because I know that I'm one voice who is speaking to the voices of thousands of persons who you can reach. Journalists are like, I'm not equating you to it, but I just want you to get the logic. Journalists are like a very popular drink. You know what that drink is? Anybody have an idea? Hello? Can you hear me? Can anybody hear me?
Yes, I can hear you. Water. I would say water.
No. Somebody take another guess. Journalists are like a very popular drink. Salim, do you have an idea what I'm speaking about?
Somehow, I can say mineral drinks.
Which mineral drinks? Anybody else wants to try?
Coca-Cola.
Exactly. Journalists are like Coca-Cola. There are people who don't know locations, but there's Coca-Cola everywhere in the world. And that's what journalism looks like. So that's I'm not equating you to the drink Coca-Cola, but I'm also trying to bring you up on the speed to know that journalists is like Coca-Cola is there's no country you go to that doesn't have Coca-Cola. At least for the countries I've been to. So it's like that. You're everywhere and people trust you. yes, carbonated beverages have health implications, but there's nobody in this room that has never tasted Coca-Cola. You get the logic where I'm coming from. So the next point is it enhances quality of care by improving the infrastructure, providing direct financial investment in primary health care. And the whole aim of this is how it helps to improve the quality of care across the nation. So let me just come back to the question I wanted to ask. How many of us have used the primary health care this year? I'm not saying how many of us know, because if I ask that question, okay, you're smiling. How many of us have used the primary health care this year? Not even that I'm sick. I've visited somebody there, or I wanted to know where my primary health care was located, or what's another word? I decided to seek care. So if you just put raise your hand if you use the primary health care. Me, I like to keep the room flowing. It makes it easier for us to have a conversation, and I'm also conversant of time. So when I need to speed up, I'll speed up. When I need to slow down, I'll slow down. So how many of us have used the primary health care? Okay, please help me check how many people's hands are up.
Okay, let me check. Not seeing any hand.
How many people
Yeah.
are on the call, please? You have an idea how many persons are on the call?
We're 14 here.
We're 14. So none of us have used the primary health care. So how do you speak to people about something that you haven't used or you haven't visited? How do you engage with them? How do you key into their human side when you haven't participated, used? Yeah?
Somebody says she has visited Zainab Salihu.
Okay. So
Says,
Zainab, please, if it's okay for you, can you tell me about your experience when you visited the primary health care? Just stating what you saw at the time you went there. You really don't have to tell me like the name of the PHC, but I visited so PHC in this location. When I got there, this was the state of the infrastructure. This was this was this. So just tell me something. If
Yes,
it's okay for you.
yes, I think I can share one of my experience. I think I went to one primary health care, even though it is within Kano State and it is within the urban community. So in terms of infrastructure, almost everything is clean and clear. But I think I went for family planning. So unfortunately, when I went there, they told me that there is no injections that are available. I have to go outside and buy the injection, then come back and collect the injection. So I was very like, how comes like this? Kaza. They told me that it is very hard for them to find the injections. So you have to go outside and buy. If not, you have to wait for another 1 week to come back again to have the dose. So I think like that experience was, I think I went more than about 3 to 6 times going there. There is no injection there. I have to go and buy it outside, then come back and have the dose. So this is what I have experienced from there. Thank you.
Thank you so much, Zainab. And this is Zainab who visited the primary healthcare where in the central part of her state. So imagine how much more people who do not have access to or cannot afford. Now imagine the number of times she went there. She said 3 to 6 times. So obviously she had transported herself from her home and to that location. She has lost human time, time rather, which she can be doing something else. So all the time she was there in that facility, obviously that's human resource time has been lost. So how many people are actually even very patient to go 3 to 6 times to the facility? You see, now these are some of the bottlenecks that make roadside and unlicensed healthcare providers thrive. Because when you go to some of these people, they're already waiting for you. They are nice to you. You are coming there, you're meeting them, you are going home, you're paying your money. Whether they're giving you the right medication, the right dosage, or even making the right diagnosis, that's another case for discussion. But even having access, and she shared something, said though the PhD was in good condition, that experience is enough to make somebody not want to go back. Exactly, because what if you have other kids, or what if that's the only time you have? And if you're working under somebody, how many times do you have to tell them I'm going to the hospital in a month for them not to see it as a different thing? So the next thing we're also going to talk about, I don't know, do we have any reactions, any question at this point? I'll pause and then we'll move to the different gateways under the PHCs. Any reactions, any questions? I'll ask, or if you don't want to ask, so that we could move on to our next point. From the ones we have spoken, if there are things I've said right now that you want us to look at, please let me know. Otherwise, I will move to the next one. Quick to ask, somebody was asking me if the meeting link is open to persons outside this circle, or it's just internal. Okay, do you mind providing me context on that? The meeting link for this engagement, is it open to other people, other persons rather, or just it's in-house, it's internal?
So we have, yes, we can share.
Okay, that's fine. So any question from anyone here? Okay, so if there's none, you're smiling. Is anybody saying anything to me? Because I can't be presenting and looking at the chat room at the same time.
No, nobody is saying anything.
So it's either I'm catching their attention and I'm really, or I'm not saying anything. So it's one of the two. So, or I've put them to sleep. Everybody's asleep. The way I'm talking, my voice is putting people to sleep.
For me, I wouldn't say that.
Okay, thank you.
Yeah.
Okay, so let's move on. Let's look at the different gateways that are under the BHCPF. So one key thing that we need to understand is that, like I said earlier, the BHCPF is a key financial mechanism under the National Health Act. It's under Section 11. And one key thing that it does is that it enables us to ensure sustainable funding for primary health care, which is geared towards achieving universal health coverage, which has been moved a couple of times, and now we're looking at 2030. So basically, one of the key fundings that we have is that it comes as 1% of the consolidated revenue funds from the federal government itself. And then also, there are also additional fundings that come from donors, from development partners. So the money that is gotten through the BHCPF is usually distributed among various gateways. And these gateways ensure that the funds address the different needs in the system. So there are funds that are targeted at improving service delivery, which will ultimately improve health outcomes. There are funds that are targeted at ensuring insurance so that more persons are covered, more persons are reached. There are funds that are ensuring that there's emergency response so that in cases where we have outbreaks, pandemics, natural disasters, there are funds that cover that. And then there's fund that covers oversight. So the day-to-day running of the facility itself, there are funds that also cover that. Now, the next thing we're going to look at is one, the NPHCDA gateway. So the NPHCDA is an acronym for National Primary Healthcare Development Agency. And then this fund is directed at service delivery and facility operations. Now, if there are no service delivery, if their service delivery and the facilities are not operating optimally, you won't get good results. Now, if the facilities are operating optimally and the service delivery is poor, you won't get good results. So these are, it's like saying, I'm trying to look at a very clear-cut, example of what I could use this for. It's like saying you drive a car, but you don't maintain it. The car will be taking you everywhere you're going, but it will not be giving you that optimal support that you need, especially when there are issues that are already happening in the system. So yes, you may have a car, it's running, but the car is not giving you that demand itself. So these funds are to ensure that they are directed at the PHC facilities for improving, one, service delivery. 2, maintenance. And 3, operational cost. Thank you. What is operational cost? Operational cost is the day-to-day running of the facility. That facility that Zainab went to that was clean, that was hygienic for her, she was comfortable enough to enter. That's what that money goes into. Maintenance looks at small repairs that are going on. Maintenance looks at correcting some of the small things that are happening. The other point is that Rehab, Yusuf, can you mute yourself? The other thing is, what does it cover? So basically, this money comes in quarterly. It ensures that there are purchase of essential drugs. And what are essential drugs? These are medications that are mandatory to be in the facility because they cover for recurrent and also persistent ailments that are within that particular location, and also drugs that are routinely used. This money is meant to cover medical consumables, like what? The hand gloves, the spirits, the face mask, the swabs, the cleaning agents, minor equipment, such as what? Hematocrit reader. Oh, I'm buying a reagent for this. I'm buying this, I'm buying that. Facility repairs, outreach services, incentive for community health workers. I say this and I say this respectfully. And one thing I've said is healthcare should not be, when somebody says I'm a community health worker, even if you're not going to pay them money, at least give them something that will reimburse them and encourage them. You might not be able to pay them their full money when they are going for community health work. But do you know how many distances some of those people have to trek when they're carrying those boxes under the sun? And then they're ensuring. So imagine somebody who is exhausted, who is tired, and then you now say, hey, you did not give my child vaccine on so day. You get that? It demoralizes them. And sometimes it also affects their service provision. Now, the money that is usually transferred to most of these facilities vary between 600,000 to 830,000, and it's usually transferred to the primary healthcare bank accounts. So for accountability, these monies are usually jointly managed by the officer in charge and the community representative, which is the WDC chairman, and then also some other key members of the community. That's why it's important that members of the community know that they can nominate people that will sit in that room to decide what that money is used for. That money is supposed to be used to benefit the facility. It's supposed to be used to uplift the facility to benefit the community. So when they're looking at their annual operating plan, or when they're looking at their business proposal or business plan, of course, this money cannot solve all the problems itself, but it's supposed to address at least the basic ones. Recently, in my organization where we're working, and we looked at clearing of grass, and then somebody is saying that they cannot come to the facility because there's grass in the facility, in the community. And then somebody else is saying, we are appealing to the government to come and clear the grass. Auntie, the money they gave you for BHCPF, what are you using it to do? Oh, am I supposed to use it to repair the borehole that is leaking? We don't have water. You know, sometimes when you listen to some persons, and I believe sometimes it's also the fact that they also lack the right information and also the attitude to understanding what service looks like. Sometimes when you're listening to them say, the facility does not have water because the borehole is faulty. We want you to come and repair it for us. And then I'm like, but you have money from BHCPF. So this facility expenditure is tracked and verified by the state primary healthcare development agencies and also independent verification agents that do that. Now, the next one we look at is the NHIA, which stands for National Health Insurance Agency. And it's a gateway that ensures that there's health coverage for everybody, for the working, for the vulnerable, for the poor, for the elderly, for children. So everybody is covered. So the purpose of this is to provide financial risk protection by ensuring that everybody, especially the poor and vulnerable, are enrolled into the basic healthcare provision fund through healthcare financing. It covers capitation payments to accredited health facilities for enrollees. It covers maternal, newborn, child health, family planning, malaria, and other basic care. And it targets that at least 1% of the population in each state is actually enrolled in the system. Accountability is through state-supported health insurance scheme. Independent verification ensures that beneficiaries receive services as covered. And not just services as covered, receive quality service. Because sometimes when you visit some facilities and they say, insurance, they'll say not available, not available. Your package does not cover. Please, and let them also tell people when they are having these conversations, people should know that there are different packages and different amount that you pay, and it covers different things. A health insurance of 50,000 monthly deduction and a health insurance of 6 million naira, you can't get the same thing. Or a health insurance of 200,000, you can't get the same thing. But in as much as you're not getting the same thing, there are basic coverage that all of you should be able to get. There are basic number of enrollees that you should have under a card. There are basic, is it an individual or is it a family enrollee? And this is happening because we've seen a lot of times where, we've seen a lot of cases where emergency situations happen. And if you're actually an out-of-pocket payment patient, you're going to struggle. And the reason why you're struggling is not that you did not do your homework, but life happens to people. And sometimes it's quite difficult for people to take a grip of themselves in that moment. But you walk into a facility and say, look, I'm a health insurance person. This is my card. This is my this. And then people attend to you. And that's how it works. So the next point that we're also going to be looking at is the Federal Ministry of Health Gateway. And this is also managed by the Federal Ministry of Health, which covers oversight, policy, and coordination. So basically, it provides a holistic oversight according to monitoring all the different BHCPF gateways to ensure that there's strategic oversight, there's policy guidance, and then there's monitoring. And this monitoring is important because accountability is one thing that we need when money is involved, especially when there's a pool of funds. So there's coordination at the national level. So you have the different steering committees at the BHCPF level. There's development of guidelines and reporting frameworks. There's also monitoring evaluation to ensure that there's three things: compliance, transparency, and accountability. Now, the next gateway that we also have is the emergency or complementary gateways. See, these gateways, we can never underestimate them. Because in a world whereby you do not have control, God has helped us here in Nigeria that we do not have a lot of natural disasters, but when they happen, they happen. So how do we prevent certain things from happening? One, these emergency or complementary gateways. So these are state level, they are integrated into the state level. So the State Primary Healthcare Board, State Health Insurance, and State Emergency Preparedness Units are the ones that handle this. They are able to manage, disburse, and align with national gateways. So one time I was in the hospital and I was in the emergency ward, emergency unit, and I was just sitting down and I was reading my book. And then somebody came up to me and said, there are patients waiting. There are patients waiting outside. You're just sitting down and you're not doing anything. Can't you be seeing patients? And I said, this is an emergency unit. I am not seeing any patient. And then she went and called the ED then, and the man came in and he was like, Dr. Davidson, you cannot just be sitting down and doing nothing. Patient, I said, no, I'm not sitting down doing nothing. I am waiting for the patients to come. While the other outpatient clinic, people wait for their turns for them to be called in. And I told him, I said, in the next 2 or 3 minutes, when emergency walk into this room, I've already exhausted my energy seeing cold cases. I hadn't even finished up to 10 minutes. There was a road traffic accident and people were coming. The same people who were shouting, now we have been waiting here, were the first people to run out at the sight of blood. Now imagine that I'd already expended all my energy in seeing cold cases that could have waited. When the emergency comes in, what happens? You're exhausted. The materials that you're supposed to use to sort out the emergencies, you have used it to sort patients that could walk in and wait at the consulting room for their care. So these emergency funds are important because not just only the funds, the trainings that go with it are important because when the emergency strikes, these are the people that you send there. So we must have funding for them to be able to say, let's pull out money for XYZ. Okay, let's pull out money for XYZ so that we could reach these people now. Additionally, you have the National Emergency Medical Treatment Gateway that has been proposed to support care beyond the primary health cares. Now, the next thing that we're also going to be talking about, and I'm using this outline because it was one that was shared with that we the social voices had looked at. We shared a topic and then they helped us understand this. So I'm going from different levels of engagement so that we could all understand. Please, just by show of hand, by a yes, by a no, just let me know that you're following. Okay, help me check. Any questions, any points of clarification, anything that they need me to say? Speak now, or that phase has passed. Yes, Sakina Ahmed, please go on. Oh, you're giving me a thumbs up. I'm so sorry, guys. A thumbs up.
People are
Thank you.
responding. Mohammed Ibrahim says yes. Promise says he's following.
Awesome.
Rahab Yusuf following. Victor Team Cat following. So people are following. People are giving thumbs up. So yeah, participants are here.
Okay, so we go on to counterpart funding. I'll share these slides with you. I'll beef them up. I'm sorry, I actually worked on my slide this morning. Shehu, I'm sorry. I had to tell Shehu, don't worry, we'll be fine. We'll wing it. So I think this is us winging it, but I'll share the slides with you. So basically, the next thing we need to understand is what is counterpart funding. That's a common term that we walk into room and people are saying, oh, there's counterpart funding, state counterpart funding, local government counterpart funding. So basically looking at it in terms of the basic healthcare provision fund, and then also looking at it in PHC financing is that it refers to the money that is contributed. So basically, this is, let me explain counterpart funding to us. Okay, we want to cook food. We're a bunch of postgrad students now. We went for a course that we're now in resident in this course, and there's no accommodation. There's accommodation, but there's no feeding. So we are giving stipends and they say, okay, we need to cook food. We are hungry. So counterpart funding is, okay, being a representative of social voices, comes in and says, okay, social voices has provided us with rice. Then Sekina comes and says, okay, me, I'll buy pepper. Rahab says, me, I'll buy Maggi and oil. And then we all cook the food together. And then Precious comes with his spoon and we're like, no, we're not giving you, we did not contribute. That's counterpart funding. So there's a primary amount that comes from the federal government itself, but then the state, which is Sekina, will have to bring her own, Rahab will have to bring their own. And then this is also to ensure that all the facilities receive sufficient resources. So everybody in the health pool system contributes their own quota to it. So basically, that's what counterpart funding is. And it is also called counterpart because it matches or supplements. So Sekina's oil and Sekina's pepper and tomatoes cannot cook the food. It can't sustain it. It's an important ingredient, but it doesn't sustain it. While Rahab's oil and spices, they are beautiful. They are core to the meal itself. But that's not what we need. We need everybody to come together so that we are not only depending on the federal funds. And then it also creates that system of ownership. Everybody knows, like, okay, we are coming to the table. Oge was the one that brought rice, but it does not mean that because you brought rice, you're going to eat 6 spoons and then we will eat one spoon. All of us have mouth in this issue. So all of us are speaking. So that's basically what counterpart funding is. So let me read it now in the right terminologies after explaining this. So counterpart funding means that while the federal government provides the BHCPF allocation via the different gateways that we've talked about, NPHCD, NIA, NHIS, NCDC, which controls what? National Center for Disease Control. They also provide that because sometimes they also have cases that we need to get to them, like Ebola, like all of those cases, surveillance, they have to do all of that. The state and local government are required to top up their PHC funding to ensure that facilities receive sufficient funding. So the next thing that we're going to also be looking at is example. So I had this example that I saw online that says if federal government provides 600,000 per PHC, a state may decide to add 200 or 300,000 from each budget to ensure that all its citizens are reached. So one important thing of this and one purpose of this is one, shared responsibility. And it encourages state and local government to take ownership of the PHC funding rather than relying on the federal government. And one thing with the federal government money, it doesn't mean that because that money was allocated yesterday, it's going to be disbursed today. It takes a while for this money to come in. The next thing is that improved service delivery. These monies can be able to cover one, human resource gap sometimes in this facility. They can help to provide drugs to prevent out of stock. They can also help to serve as staff incentives. So once in a while, let's also appreciate people that work in the PHCs. Every time we are complaining, doctors and nurses and healthcare workers are not doing this. But you forget that they also have families, and sometimes the monies that they receive are mega and they're not able to cover all their resources. So you find one health worker, a nurse, working 2, 3, 4 shifts. But when this counterpart funding comes and we say, okay, we know that, okay, things are difficult. This month we are going to provide XYZ, maybe small bags of rice, 5 kg bag of rice. It takes off a huge burden from them. Sometimes it also serves as a reward system for community health workers to say, oh, look, at the end of this month, based on the work you have done in terms of immunization coverage and awareness, we present you with this small food flask. Utilities, outreach programs, sensitization engagements, sustainability. It reduces overdependence on federal funds and donor contributions. There's a thing that people used to do, and I think it's also sad. And some people have this notion that when something is given to them for free, they don't need to disturb themselves. After all, they'll get it again. But you know, when you pay for something out of pocket, there's always this thing of, my money must not waste, though. I must use it. I must achieve that which I'm supposed to use it for. So that's one thing that it also does. It also prevents overdependence, and then people have that shared responsibility itself. And then lastly, equity. It ensures that the facilities in the rural and poor areas receive minimum, facilities in the rural and poor areas that receive minimum level of funding for essential services receive that service that they need. Now, counterpart funding is something that you need to be able to engage at the local government and at the state level. And one way we can do that is to be able to engage with communities, let them know that this is what is expected at the state level. Now that local governments have autonomy and they have some money with them, how is that money being utilized? Then the last thing we're going to be looking at is last mile. So last mile is like when you're playing a deck of cards and you hear last card. So last mile means the PHC facilities. So last mile when it comes to delivery. So for example, I'm producing something. My last mile is usually the person who receives those services, the citizen, the person I'm delivering it to. So that's the same thing that equates to the last mile itself. So the last mile receives to the PHC services themselves. Is the point of where health services reach the citizens, especially in rural and underserved communities. So whatever funding gets to the last mile is like funding that comes from the federal, goes through the state, goes through the LGA, goes to the PHCs, irrespective of where the PHC is located at that point. So this is like a proportion of what these facilities receive to support their service deliveries, their staff, their drugs, their patient care, as opposed to the funds spent on administration, logistics, or state level management. Now, so these are current fundings that we currently have in our allocation. So if a facility is receiving 600,000 per quarter, and then we're looking at it covering 2.4 million naira a year. If the proposed increase from 600,000 to 880,000, you're looking at 3.52 million naira a year, or we're looking at a middle ground of 3.2 million naira. Is this actually sufficient? to run a facility. It depends on the location itself. And it also depends on the patient load and the services that are provided. I can't expect this amount of money to comfortably run a facility in Kano town, Kano metropolitan city. Or I can't expect it to run a facility in a community that has just one PHC facility that covers that facility and neighboring communities. It won't work. Now, there's a question when sorry, excuse me, just give me a minute, please. Just 1 minute. 1 minute, sorry. So the question I was asked, is 800,000 sufficient to run a primary healthcare facility? Well, like I said, it depends on the location, it depends on the patient load, and it also depends on the services that are amounted to it. So if we're looking at 800,000 naira per quarter, that's 266,000 naira a month. It's modest, but with the rate of inflation, it won't work. And that's because you are forgetting that there are basic operational costs, such as the utility. Let's hope that this facility is the government facility, it's not a rental property. So the money that is covering electricity, water, cleaning, and waste disposal. Then let's look at purchase of consumables. Now you're looking at drugs, syringes, gloves. Gloves that used to cost 500, 700, 1,000 in 2014 are costing almost 5,000 at some point. Let's look at the repairs. Let's look at painting of the wall, servicing the building, servicing of equipment. Let's look at community outreach. Nowadays, people don't want to come to community outreach except you want to give them something. If they're coming for awareness or sensitization, they will ask you for what? Refreshment. Some of them will even tell you that you should give them transport. Now, this is also looking at services that will also cover monies that will also cover transport reimbursements and all of that. It won't work. It's not, let's be honest with ourselves. It can be functional, but it will not be transformative. That's VIP treatment you're looking at when you come to the facility. You can't get that with this amount of money in this state itself. So there's something that I saw that says that 800K a month can help a PHC functional, but not necessarily transformational. It can keep the light on, ensure that some basic drugs are stocked, minimum outreach are ongoing, but it cannot function for major infrastructural repairs, ensuring that staffs are adequately staffing is adequate, and then also there's new service line in terms of service delivery. Now, 3.2 million naira a year is far below optimal funding. WHO has benched that it is essential for primary health care to receive roughly $60 per capita per year, while in Nigerian PHCs, that is often a fraction of that. That's what they receive. Many PHCs serve a minimum of 5,000 to 15,000 persons. So 3.2 million naira is an average of looking at 200 to 600 naira per person annually. For a year, it means that when you go to that service, you're paying 200 to 600 naira. Now, the other thing that also affects this money is looking at leakages and delays. So when pockets are leaking, when there are different bottlenecks that happen, even this money doesn't get to the right people at the right time to be able to address their issues. And lastly, before we move to the final point, I'm still in time within my time frame, is all of these things that we've talked about, looking at the BHCPA, looking at the different gateway, looking at the funding, looking at counterpart funding, looking at the last mile, all of this will not work if there are no accountability mechanisms. And sometimes when I sit in rooms, I I try to keep my facial reactions a bit to myself, because we have different structures in place. But what use are these structures when there are no accountable mechanisms for them? So it's important that we follow up with what gets to the last mile. I said earlier that it is not just about people receiving money via, Ali, you please mute your mic. It's not about people receiving monies via allocations. It's also ensuring that these monies are well tracked, managed, reported, and utilized for the last mile itself. Now we look at how the accountability mechanisms that exist around the PHCs to ensure that these monies that come in via the BHCPF funds are utilized for the purpose which they were given. One of the key accountability mechanisms that we have at the community level is the WDC structure itself, if rightly used. And that's one thing that we've done at budget itself, to look at this WDC structure is there. How can we reignite it? How can we ensure that they know what they're doing, the right people are on that position? And it's not just about power itself. It's about ensuring that the people that are there understand the mandate and are willing to provide that support. Other things, we also have vocal persons. We have our religious leaders. We have our community members. We have our youths in the community. Those are the different gateholders and stakeholders in the community that should be part of these accountability mechanisms. Before we now go to civil society, some persons operate civil societies without understanding what it entails and without understanding what is required of them. So there are different accountability mechanisms under the BHCPF fund itself. So sometimes people are asking, show us the name of the facility where this money is going. Tell us this, according to what Oge was saying earlier. Sometimes these are not the right questions you should be asking. It's not just about tell us the money. It's all of this sensitive nitty-gritty. One is looking at institutional and administrative accountability at the national level. So the Federal Ministry of Health provides this. It provides oversight and also policies. Now, the other one is also that it also ensures that there's one key thing. There's coordination among the various BHCPF gateways that we talked about earlier. The next one we're looking at, or we're going to be mentioning, is the state level. So there's the State Primary Healthcare Board, State Primary Healthcare Development Agencies. There's a state the board or agency, depending on the place you find yourself. There's also the State Ministry of Health that also looks at the funding that comes in. And then all the states also have steering committees that coordinate for accountability. And I remember sitting in one of the steering committees for Kaduna, and I was quite impressed, because that steering committee was chaired by the deputy governor, who is a healthcare personnel. So she knows the questions to ask. She knows the right things to ask. So that gave me something of saying, oh yes, this is important. Then at the last mile itself, there's facility level management. And that's where the WDC comes. The community members come in, the traditional leaders come in, the health workers come in, the religious leaders come in, the youth people come in, the women group come, the men group come, the persons with disability come in. There must be representation at that table. Now, the next thing is, these monies must be deposited into a dedicated PHC account that is jointly managed. So it's not only the facility in charge that has access to that money. The facility in charge may say, no, I need this money to be able to, she might say, I need this money to be able to, I need this money to be able to buy drugs. And the community member is saying, no, you cannot use it. We need this money to be able to repair the borehole in the facility. Are both of them important? Yes. But then people also have to decide which one is beneficial, which one has more health implication than the other. So we can't just agree and say, this money that we have is only the in charge that will use the money and tell us this one. The money has to be agreed upon, what is supposed to use, and it must be to the service and the benefit of who? The community members at large. Then lastly, all expenses must be recorded in the financial register. So there's this business, they have their business plan, they go, they sign, they show how the money is utilized, and at the end of the day, it must be registered. And then there's a quarterly financial report that is submitted, and all these documents are verified upon supervision. So these community based structures are critical because, one, they are represented in they are resident in the community, they are participatory, they are visible, and then they're also supposed to know where these monies are going. So they are the foot soldiers that are on ground. Ooh, the next thing that is also important when it comes to accountability and transparency is that there must be performance monitoring. So we must be able to look at scorecards and look at how much coverage we're having, not the doctor thing. So there's something that we do under our project in the Strengthening Health System. We have a utilization form that captures PHC attendance. We want to know how many people attended the PHC last month, how many of them are in this month. We want to know how many services that are being offered. If they offered 8 services last year, have they added an additional one? Have they dropped an additional one? We want to know those questions. The next thing that we also want to know is immunization coverage. Are we meeting more persons? Are we covering more grounds? Are more children getting immunized in the community? And these things are important because the more children get immunized, the more there's like resistance to outbreaks for children, especially for under 5. It means that the more the children will be in school, the parents will be at work, more productive time. As opposed to when the child is sick, the mother can't work. The father has to go and look for money. The resources that are supposed to be used for other things are used for treating the child. So it's also going to also have its impact. The next thing is looking at independent verification agents. That's where people like us come in. The media, we are going there, we're looking. We are having NGOs, other NGOs, budgets, code. We are looking at consultants, having consultants to come and also verify what is going on. And then also some states also use digital tracking platform. Budget has a digital tracking platform for financing, healthcare financing, where people can go and say, look, how much was allocated to my facility from the LGA? The LGA person, the facility person will look at it. Everybody can see how the money was used. There are evidences that are attached to it. The LGA person can come and say, oh, there are 15 facilities in my LGA, and this is how much was allocated to each and every one of them. And then he can print a quarterly statement and utilize it. So budget, code, the PLSI, there are other accountability tracking mechanisms that have been crucial to ensuring that there's performance monitoring. They may not be able to cover everywhere, and that's where the media comes in. The first accountability mechanism is the citizens themselves, the community members, because they are residents, they use the facilities, they can provide you real-time data. Some of the challenges that come with accountability is delay and leakages. So we talked about money being allocated, time when money are disbursed. We talk about weak capacity. So one thing that we're also doing in the coming weeks is I'll be somewhere in Kaduna. We're going to be having a training, like we're having something like this for the WDC. So some of them will come in, and some of them are elderly, they have brilliant ideas, they have expertise, but they do not know how to digitalize their work. 1. 2, bookkeeping is not an easy task. There are criteria for bookkeeping. And then the thing is, how many people know how to keep their books clean and open? And then secondly, how many of them also know how to have the right information on it? Now, with also digitalization of bookkeeping, we will not be hearing stories like, oh, fire gutted the building and everything is gone. Oh, somebody ran away with the books. We can't find the books. The other stories, termites have eaten the books. There are digital platforms in which we can be able to have that. And then the last 2 parts is we have limited public access. So financial data is like sacred. When you tell somebody, can I see your financial record? Are you calling me a fraud? Are you doing this? No. It's for transparency purpose. It's also a purpose that helps us look at gaps to say, let's provide more funds to this person for this. Let's do this, let's do that. Then the next thing is tokenism, where community involvement. And then you look at a lot of communities where they are there, but they do not. Communities are present and they are not having that influence. Sorry, 1 minute. The communities are present, but they do not have that real influence. Their voices are not there. So how can we strengthen? Ali, please, could you mute your mic, please? How can we strengthen accountability? One, to be able to strengthen accountability, we must ensure that the funds really reach and work at the last mile. So they must be direct, they must be traceable to the PHCs. We can also use real-time data, and especially in digital forms, to be on a public dashboard to simplify. We could use infographics. There must be a mandatory sign-off before quarterly fund release. And then having a citizen scorecard and open data publication like what budget has on the PHC tracker itself is an avenue that gives us a feedback to provide that engagement at the community itself, to say, look, this is how much has been put in. And then occasionally we should have routine independent audit and sanctions for misuse. So anywhere we find out that there's gaps, we can actually provide trainings for them. And anywhere we find out that there's like mismanagement of funds, there's for that. Now, what can we as media persons do to encourage citizens and also to monitor? We could encourage them with the right information. First of all, they must be able to know how these funds are gotten, the different gateways. They must be able to know how these funds are disbursed. They must be able to know how these funds are spent. Lastly, they must be able to interact with their facilities. So they must be able to know what services are available. And then this is not just having the service available. Are you receiving the quality and right service? They must be involved in facility day-to-day operations, such as the facility maintenance. If something happens, and they should be involved to know, this is our PHC, it's our own. This is what's happening, and this is how we should maintain our facility. And when they are reporting, citizens should ensure that there's transparency. If a facility is not doing well, state it. See, until we begin to hold certain things certain practices and certain persons accountable, we will not be able to have that quality care itself. So for example, okay, I'm going to use you again. Okay, goes to a tailor, and the tailor takes her measurement and decides to sew a 5-year-old dress for Oge. Beautiful, everybody's admiring the dress. The tailor is a good tailor, she has sewn. But did she sew what is tailored to Oge's need? No. Will Oge ever use that dress? No. So it's not just saying, I'm a good tailor, I provide quality service, look at my handiwork, and then you're giving me a dress of a 5-year-old. What am I supposed to do with it? It will not fit. Citizens can benefit through these things because it means that once they are involved, they will have more reliable PHC services. People now know that they are watching them. Healthcare workers now know, I cannot talk to you rudely, I cannot talk to you badly. I know sometimes people will say, the healthcare workers are rude. Doctor, are you sure you're a healthcare worker? I say, you've not seen me on a very stressful day. All of us have it. But the thing is, how am I able to ensure that I'm able to communicate without being derogatory, without being disrespectful? So reliable healthcare services, access to essential drugs is one key thing that people will benefit once we have the right information, and that's why your voices are important. Lastly, we are able to generate accountability in government, trust in government programs. A lot of people have lost trust in the government system, in the healthcare system, even in the media. And when people tell you their stories of engagement, sometimes when I walk into rooms and some persons come in to tell me what they faced in the primary healthcare system, I just sit down and give them that forum to speak. And I say, look, we can't erase the past, but we can make sure that it doesn't happen again. And your voice can be a champion for it. And in all of this that we're doing, what are we aiming at? Improvement in health outcome. We are looking at universal health coverage. How do we achieve universal health coverage? How do we achieve dignity? How do we achieve communities being sensitized? How do we achieve communities knowing that this is the right place to go? And in all of these things, we're going to be reducing quackery, visits to unverified medical practitioners, visits to mushroom clinics. We'll begin to, we don't know this impact on health until it affects us directly. So it's a call for us to be able to do the right thing and do it well. So lastly, I want to say a big thank you. And if you can look up on my screen, you're going to see your voice matters in the health ecosystem. Silence costs us more. Thank you. And I am going to turn on my camera now. Most times I try not to turn on my camera before so that people listen a bit. So just give me a few minutes. It's a big thank you for me, for you listening and saying to you that your voices matter. It's me. This is what I look like. Hello, okay. Hi. This is what I look like. So it's a pleasure meeting everybody. Thank you so much for your time. So I'm open to taking your questions and just let me know what the next line would be. But we're still within time, so I have 15 more minutes to the end of the class. So thank you.
Okay.
Stop my video.
Thank you, Dr. Davison. Thank you for your very insightful session. Please, can we give her a virtual clap, thumbs up, something to appreciate her? She's really done very well, very eloquent. I really enjoyed her session. I'm very sure a lot of us did, and she has given us a breakdown of our roles in tracking some of this the primary health cares and the facilities and all of that. And then for me, one thing that stood out is the part where she says it's a shared responsibility when it comes to funding. So it's not just the responsibility of the federal government to fund this project. So it's like the states, the local governments, everybody is bringing resources to fund the health facilities in communities. So it is really important to note some of these relevant details for those of us that would want to go ahead and write very impactful stories. And so for me, it is very important that she has highlighted this and she has given us a very good breakdown. So I would like to ask people. Okay, she has actually dropped the link on the chats in the chat box, so we can all check it out. And I'll still share it on the platform, on the general WhatsApp platform too. So please, if we have
Okay,
any
let me just
questions.
provide some context to the link, just while people are putting their questions together. So it's a digital platform that looks at the primary healthcare across the nation. So you can check your primary healthcare itself to see what it looks like. It's been updated. We're currently running through the nation. We know we have NPHCD says we have roughly about 30,000, but then 8,000 are functional. Level 2 facilities, they're increasing to 12,000, but currently we have over 3,000 to 4,000 PHCs and over 4,000 PHCs, and we're spreading across the 36 states, including the FCT. So you can look at what it looks like, engage with it. If you have any questions, you can reach out to the social voices. It's a digital platform that provides you with an opportunity to provide feedback on the state of your primary health care. It's a very cool interactive platform. It doesn't take so much in terms of engagement, and you can provide a feedback either as a patient, you can provide a feedback either as a citizen, and all in all, it's looking at how do we contribute, because we have some back of data itself, data expertise. to be able to provide support to the government, and also to be able to provide support to the work we do. So this is what it looks like. There are facilities on it, so you can do a state. So let me start with let me just go to Akwa Ibom. So these are PHCs in Akwa Ibom that have been uploaded on it. If I filter by state and I go to Kano, let me go to Kano. Hold on, please. Let me go here to Kano, filter PHC. So this is 1 minute. This is not the only PHC in Kano. So if I go to Kano, you can click on this icon. These are the PHCs in Kano. You can provide a feedback either as a concerned citizen, or you can provide a feedback as a patient that receives care. If I come back here and I say I'm going to reverse, so I'm just picking states in different geopolitical zones. These are PHCs in Port Harcourt that have been profiled on it. It's quite interactive, and reach out if you have any questions to ask me about it. How can you engage people using it to ensure that shared social responsibility and accountability, especially at the community level? Okay, I'll keep quiet now and I'll hand over to you. Thank you. Sorry for jumping back in.
Okay, thank you so much for that explanation. I think it's going to help participants, of course, journalists, to help us do better stories, and we'll share the link in the group as well. So we're moving forward to the question and answer session. So please, if you have any question for our facilitator, it would be nice to ask it now so she can provide adequate responses to them. Or maybe if you have contribution on story or something to to talk about on the topic, can also uh, indicate so we can give you the floor to speak. Do we have any questions? Are we all here? Okay, Salim Shehu wants to say something. Salim, please unmute yourself and go ahead.
Mine is just simple. She has talked about the futures and significance. I need, if it is available, and to add more about it, because I somehow confused regarding to the futures and strengthen, like comparison between the key futures and the significance. I want to have some more clarification about it.
Dr. Davidson, please, did you get that question?
His voice was muffled, so I was going to ask you if you got it, but maybe if you got it, you just let me know.
I actually didn't know. So please, Sani, can you please
Maybe type
ask
it in the
again,
comments,
repeat
or
it,
yeah.
or maybe ask again, yeah. Repeat the question or
Oh, okay. I said I can you hear me?
Yes, we can.
I said the significance and the futures you have mentioned in your present have some kind of more explanation about them.
Okay, I'll try and wrap my head around that, but okay, maybe just take some more questions and then we'll answer to what we can. Okay, do you want to take some additional questions?
sorry, I didn't know my mic was muted. Sorry. Oh yeah, me, please go ahead. We're taking more questions so we can get all the responses together.
All right, good afternoon, everyone. Good afternoon. Is it Ma'am Davidson? Thanks for the wonderful session. Actually, it's understanding. I mean, it's self-explanatory, like each, and it's really rich in context. Okay, my question. I have two questions actually. I'll be asking one as a journalist, and the second, I don't know if it will be as a citizen and as a journalist. Okay, the first question is this. When you started the session, you asked that how many persons has been to the has used the PHC, the funding, like I've been to the like PHC this year, and it's only like one person that actually raised their hand and explained to us like she has been there. So why growing up, right? Please just follow carefully so that you actually get the context of what I'm trying to ask. So many persons has distrust in government. Yes, because many people will raise their eyebrow that what are they really offering? Like what service are they offering in these PHC centers? Like it will not be quality service, it will not be enough. So that makes most citizens lose their trust in PHC service and facilities, because when you get there, most times it's offering poor service and poor quality service delivered. Now, how can the media make the people, how can the media help the people regain their trust in PHC service? I know you actually mentioned it in during the, but like how can we convince them enough? Because there are some communities, like not even communities, especially among the airlines, you can't convince them, most airlines, to actually use the PHC facilities, because it's just like they can't offer me the kind of service that I want. That's number one question. And now number two, during the course of the class, you talked about, I don't know if I get it right, 800,000 naira being the budget or the money allocated to maybe some communities. Now, this money is even barely enough to, considering our population, this money is barely enough to make PHC service. It's barely enough to make it make the PHC offer a quality service to their patients. Like, now, if we keep on telling people go to PHC, go to the PHC, like go and get good healthcare facility, quality, and all of that, this money that is barely enough, considering our population, like how can people have access to good quality service when the fund is even barely enough to offer the kind of service they want? I don't know if you understand my question. I don't know if you get it right. So please, can you help? Can you enlighten me further with that? Thank you.
Uh,
You're
Thank you,
welcome.
Oyemi, for the question. I think we have one more question from someone, Zainab Usman. She says, when writing a report on a particular PHC, can someone use the issues within the PHC website highlighted? I don't
Yeah,
know if that
sure.
is clear. Okay.
Yeah, sure. So if it's something that is tied to, if it's something that is tied to your location, that, or something that is relatable, you can say based on findings. So what you're getting now is like a secondary data source, but then you must also reference it to say this was information that was getting from so facility. But please, when you're doing that, you should also ensure that you leave out the patient's information. So you don't mention their names, you don't mention that, but you say based on this is what's the findings were that have been gotten from XYZ facility or XYZ location. So that's perfectly fine. For this other, for the young lady who had spoken some minutes earlier, yes, I know, because in as much as we say, look, this is the system, this is where we find it, but we need to do something, because we can't we can't we can't leave it to chance. And one way we left it to chance was during the COVID. You saw how people who even had the money itself could not get the care they needed. The elites were also using the primary healthcare during COVID. So why is it that right now we can't use the primary healthcare anymore because there's no COVID or because there are no restrictions? So it shows to you that we don't want to be in that situation where there's an emergency response and God forbid, there's nothing we can do. And this is our first line. So the primary healthcare itself is the first line of your health system. If it fails, everything fails. If it succeeds, everything succeeds. If it's collapsing, everything is collapsing. Because they reach more persons than what's happening? The screen is blank. Do you want to turn it off? No. Hard press, hard reset. Press it for a while and then yes. So okay. So we need to be able to mobilize our primary healthcare because in as much as there's this distrust, well, there's nothing we can do about that. We can change, but we can change the narrative. People should be able to visit these facilities knowing fully well that, okay, the last time I came here, these services were not available. See, the amount of time that people have to spend going to tertiary institution is a waste of time for a service that should have been accessed by them. A mother that has 6 children or a mother that has children that are in school in her area will now have to transport herself to one facility, and then that facility, what now happens to the other children at home? When she could have easily gone to the primary healthcare, received that service and returned home. So that's where you come in. You're not telling people that, look, I'm pledging my case that this service, where you go to that hospital, you receive the best treatment. But the more people begin to use these services, the more they begin to experience the changes that come with using these services, the more they will begin to voice their opinion, the more they will begin to push for change. But until then, we can't just leave issues to chance, and we can't just say, oh no, because this service is not working, or yeah, me, then we leave it at that. So let's see the people who are actually willing to use the service. Let's see that they get quality service itself. Some of these vaccines, I remember one of my friends telling me that she was paying like close to 200,000 in a private hospital for immunization for her baby. Anytime she goes for immunization, 200 and something K. I was like, you have plenty money, or something that you would have want primary health care, you'll not even spend up to 10K or 5K. That's even if you are generous. And you still get the same quality vaccine that you're getting from. So you see the system, how many persons can afford that? And then the other part of it is the one still falls on you and me to be able to have people engaged, to be able to have the right people communicate, and then to be able to have that information. For Sally, so I think you talked about you were mentioning about key findings or something that has to do with functionality. Maybe you joined us key functions and goals. One thing that I know that might be quite helpful for your question, because I actually didn't really get it, is if we share the slides, maybe they can be able to provide you some form of some form of in-depth understanding rather. And peradventure, it still doesn't serve its purpose, please feel free to write to the organizers, and they'll reach out to me, and then I can be able to provide you with some clarification. But I in all honesty, I really didn't get your question. But I'm trying to also keep to time because in a couple of minutes, I will be jumping on another call. So I think that's where I am at this moment. So okay, over to you. For anyone who has additional questions that want to reach out, feel free to write to me via email, write to the organizers. Okay, I have my call at 2 p.m. Feel free to write to the organizers. They can reach me. You can reach me via any of my social media handles, especially LinkedIn, and then we could take the conversations to the next point. So thank you so much for having me. Okay, over to you.
Thank you, Dr. Davison. It's really,
You can call
really...
me Dr. B, don't worry. I know the Dr. Davison sounds very formal. So most times people just call me Dr. B. It's fine.
Okay, Dr. B. Thank you, Dr. B, for your very insightful learning process and training. It's something I honestly enjoyed. And for me, the key takeaway is policy is only as powerful as its impact on the people. So this reminds us that accountability is very important and must drive our storytelling. So, as journalists, our responsibility is to help citizens see where reform stops and responsibility begins. Once again, thank you, Dr. B, for sharing your insights, and thanks to everyone for joining this very important and insightful conversation. Your inputs, your questions made it very enriching. So let's keep telling stories that hold power to account and make public health reforms truly public. See you in our next session, and let's keep the stories coming. Do have a great day and enjoy the rest of your week.
Thank you, everyone, and bye. Bye from me.
Bye, everyone.